let's talk about finger thoracotomy. It's a nice looking slide. I want you to get the full benefit of seeing it without my mug in front of it. Finger thoracotomy, as opposed to needle thoracostomy, as opposed to needle decompression of the chest in trauma. We had this discussion recently at a meeting I was in, and I was sort of equivocal on it at the time. And I've since talked myself into, this is a really good idea, and this is an ALS level skill, or should be an ALS level skill, because if we want this to be useful at all, if we want to save lives, we need to have it. And so I wanted to share this with you. Thanks, John. Again, I can appreciate the comments on the slide. It is a nice looking slide, though. That's a good template. There I am again. Let's talk about finger thoracostomies. Why should you do a finger thoracostomy, and why should it be in the ALS scope of practice rather than the needle thoracostomy, or alongside the needle thoracostomy that we're currently used to doing? So, as you may know, I work at the University of Cincinnati. Most of the local fire departments are on the Southwest Ohio and now Northern Kentucky EMS protocols. And basically, it's a big group of people that all get together and put these out. And they're pretty good protocols. If you have any, want to see what kind of the best that we've got at the moment is, I think these are close to it. And they get updated frequently. And it's a big group of people with a whole bunch of stakeholders all involved. Anyway, it's at the Hamilton County Fire Chiefs Association website if you want to see it, Southwest Ohio Protocols. Anyway, this is what most of our local fire departments will operate off of. And this is the traumatic arrest protocol. And it's kind of a lot. This has kind of been in place for a little while now, so it's not new for a whole lot of people anymore. But it is something that bears repeating at least a little bit. And at some point, I'll actually need to talk about the trauma protocol itself. But this is traumatic arrest. So if you die as presumably a result of trauma, this is the stuff that should happen to you at the time. And there's a lot of words. I will break it down fairly simply. You want to control hemorrhage for the person. You arrive on scene. You see the guy pulseless, presumably as a result of trauma. You want to control hemorrhage. You want to decompress the chest. You need to manage the airway in one way or another, maybe with a bag, maybe with an ET tube, maybe with an iGel, whatever it is, effectively manage the airway and ventilate and oxygenate, and then give some form of volume. At that point, should you consider putting the monitor on the patient and make a decision based, after you've done those interventions and put the monitor on the patient, you can base your decision to transport or to stop resuscitative efforts based on their rhythm and their heart rate. And basically a slow or asystolic PEA will lead you to terminate if they're in VFib, or if they're in a fast PEA, then you would transport. So what's this based on? Basically, it's based on controlling external hemorrhage, giving volume to help with external hemorrhage, or internal hemorrhage for that matter, controlling hemorrhage, let's call it that, managing the airway, and decompressing the chest. That decompressing the chest part is the one I want to kind of get in on. Controlling hemorrhage, we can talk about at some other point. Giving volume, we can definitely talk about at some other point. And the airway is its own topic. But let's talk about decompressing the chest. Pneumothoraces. Sometimes they're somewhat subtle. Sometimes they're not subtle at all. Sometimes they look like other things. But what is a pneumothorax? It is a collection of air outside the pleura of the lung, outside of the lung itself, outside the alveoli, but not outside the chest. So it gets trapped in there. Now, most of the time, a pneumothorax isn't a big deal. It may cause you to have some decreased excursion of the chest. It may be painful. But most pneumothoraces are not the tension pneumothoraces that we were about. In a tension pneumothorax, you actually develop pressure because there's a one-way valve that gets built into your torn up lung tissue in one way or another. So air is able to escape into that space, and it's usually under pressure. You squeezing the bag it puts pressure into that area and inflates it like a balloon. And then causes you to shift your mediastinum over a little bit. When you push on the heart, it's not so much that you compress the heart, because the heart's relatively rigid in that way. But when you shift it over, you decrease venous return to it because you compress all the squishy blood vessels on the venous side, and you impair blood flow to the heart, and eventually you die as a result. It's one of those obstructive shock kind of pictures because you just literally compress the blood flow into the heart itself, among other things. Pneumothorax is a little bit complicated to take care of, though. If we say control hemorrhage, Well, it's fairly easy to see if hemorrhage is controlled. Maybe not in your belly, maybe not in your pelvis, but certainly external hemorrhage, we can say, oh yeah, I've controlled that hemorrhage. How do I know? Well, it doesn't seem to be bleeding anymore. That tourniquet is effective. Our intervention has been effective. Same thing with volume. Does blood pressure come up when you give them the volume? If it does, it's effective. If it's not, it's not. We know about whether or not it's effective or not. What about our airway stuff? Well, we have end-tidal CO2 monitoring and a SAT probe that lets us know that we are both oxygenating and ventilating, and we've effectively controlled that airway, at least for what we need to know right now. However, dealing with the pneumothorax as part of that, the decompressing of the chest part, this is a little bit harder to tell. Because if you stick a needle into somebody's chest, you theoretically are going to get this rush of air come back. And then you're like, oh yeah, well, I've decompressed the chest now. I've taken the pressure off and the lung can now expand out a little bit. We stop squishing the mediastinum and everything's good. The problem is that really a lot of times you don't get that big rush of air. Or even if you get that rush of air, was it effective? Like, did it completely decompress the chest? Because as soon as you pull out that metal piece, the steel piece in most of these catheters, if they have any kind of like muscular chest wall, or if they're tight or anything like that, the catheter itself will compress and it'll stop draining. So you may get that rush of air, but like, did it completely go away? Did it go away enough? Is there still a pneumothorax in there? Do I need to do it again? Sometimes you don't even know if it's gotten in the right spot. Like say you put it in there, put it into the chest, and you don't get a rush of air come back. Does that mean there was no pneumothorax? Well, no, it may just mean that you didn't actually get into the pleura. Maybe you're hanging out on top of the rib. Maybe your catheter is one of those short, little stubby, little like 1.25 inch ones for some reason, and you're still just sitting in the chest wall. So lack of air coming back doesn't guarantee that there is no pneumothorax, and barely even tells you that maybe there's not, as well as rush of air coming back doesn't guarantee that. Lack of air coming back does not guarantee that there is no pneumothorax. Rush of air coming back does not guarantee that you have effectively treated that pneumothorax, unless the patient all of a sudden like regains spontaneous circulation. So the way that we are doing needle thoracostomy, needle decompression of the chest, is questionable in its efficacy and questionable as a diagnostic tool, sort of at best. But it's sort of the thing that we've done. Now, don't let me say that needles don't work. They do. And here's proof of it. They had a thoracoscope in this guy's chest, and here it comes. There's the needle. And we got to sit here for just a second. Needle there, and this is again this is the big dart. This is a fairly rigid catheter that you'll see here in just a second. But you see that it has entered the chest, it has gone into the space, the lung is expanding with each breath, and this was effective. If it was a tension pneumothorax, it would have effectively let the pressure off. But even as a simple pneumothorax, the lung is expanding into that space as you're allowing it to drain out. This can work. If you have the right equipment and you do it in the right way, the needle does work. The problem is that it doesn't always work. Some of that is a technique thing. Some of it's a position thing. You've seen in probably a number of papers where people get needled and then somebody does a CT on their chest and they say, oh, well, look, the catheter couldn't possibly have gotten into the pleural space because here it's sitting in the chest wall itself. And the chest wall space is, it goes from... let's see here. Chest wall goes from like here to here, and that needle couldn't possibly be there. Well, even I will tell you that if you have nothing better than a needle, then fine, use a needle, because that's based on a completely non-squished chest. If you take a needle and you squish down on the patient's chest with it, I can decompress my own, or I can compress the soft tissues of my own chest far enough that I bet I could get 1.25 inch needle in there. We squish, we're humans. So I will even say that an attempt at a needle, even if they have a big fluffy chest, is better than nothing. And I think that many needles may actually make it into the chest itself, but as soon as you release the pressure on it, they may kind of slide back out. So you've probably seen a number of studies that say, oh, our chest walls are too thick to even accommodate a needle, which I don't believe is entirely the truth. But when you look at what actually happens, if you are able to successfully decompress a chest, it's probably under 1/4 in thoracic trauma. And this is a little bit hard to really kind of fed out 100%, but probably under 1/4 of the time are we successfully decompressing a pneumothorax with a needle, at least in this guy's clinical review of it. And this is from 2015, is from where this data is from. However, close to 100% of the time, or closer to 100% of the time, it's like 85% or something like that, when you use a chest tube or put an actual hole in the person's chest, the pneumothorax becomes decompressed. Data kind of showing the exact same thing again. How often does needle decompression work versus finger thoracostomy, basically putting a hole in the side of the guy's chest and letting the air out. Thoracostomy works about 100% of the time because you're putting a hole inside the guy's chest and you relieve the pneumothorax. Overall, about 3/4 of the time do we think that the needle remains patent. Just over half of the time did it actually seem to relieve tension physiology, and was overall successful under half the time at about 2 out of 5 or 40% thereabouts. And if you look at guys that were in cardiac arrest, this is a pig study, by the way. So it, inflated the pig's chest. We know there's air in there. The needle was effective at about restoring. The needle was effective for relieving cardiac arrest caused by that tension pneumothorax about 40% of the time. 40% of the time, the pig came back when you needled their chest. 100% of the time, the pig came back when you did a finger thoracostomy, when you put a hole in the side of the pig's chest, which is a kind of startling thing. So it probably is a much better, much more appropriate, efficacious tool, or not efficacious, effective tool. Efficacious would be the needle itself. Now, pneumothoraces, even in the setting of having a chest tube in place, are not always super easy to clear. In this case, you see that pneumothorax developing here. And what's this thing? This is actually a chest tube that's there. So even in the setting of having a drain in place in the chest, it's not 100%, but certainly much more effective than just having that little needle. So even having a 32 French hole in the side of the chest that is fairly rigid is not 100% effective. You can imagine that little tiny 14 gauge needle or 10 gauge needle, even if you're really going at it, that may make that you may be trying to relieve it with. Even that may not be effective. Long story short, tension pneumothorax is out there. Tension pneumothorax is difficult to diagnose, especially in the field. It's difficult in the ED, it's difficult in the field. It responds very well to appropriate treatment. Again, remember the pigs. If you successfully decompress their chest, then they come back pretty much every time. But nothing that we do treats a pneumothorax otherwise. Managing the airway doesn't treat it. Giving volume doesn't treat it. Controlling hemorrhage doesn't treat it. The only thing that treats a tension pneumothorax is decompressing the chest. And so we have to decompress the chest. Like it's what you have to do. If you want to bring this number of people back, then you have to be able to decompress the chest. And the best way to do that is to definitively, this is the same graph I showed you before, definitively put a hole in the chest wall to let that air out. By the way, it's sort of important to mention, I'll get that in just one second. It's sort of important to mention that the primary causes of death in the U.S. After trauma are number one, head injury, number two, hemorrhage, and then somewhere way down the list is pneumothorax. It's probably somewhere between 1% and 5% of deaths after trauma is the estimate. Head injury is going to be much more common, hemorrhage a bit more common than that. But still, this is a relatively easy thing to do. And if we can do it, it is probably, if that is the problem, it's going to save somebody's life, almost certainly. Here's an example of how you see that. So I think this is a pig lung inside a bag. This is a really nice model. You can see that he's going to attempt to squeeze back there, and you don't see the lung really inflating at all. This was just putting a small hole in the side of the chest, like you might do with a needle decompression. You still see the lung. The lung now expands a little bit more than it was a second ago, but it's still kind of squished. It's not until they get a finger in there, make a nice big hole, like you would doing a finger thoracostomy. Now the lung comes back up. Tension has clearly been relieved, and we know this was an effective treatment. I'm not the only one that says we should all be doing this because, and we really all should be, because this is the best way to do it, and we need to make it our standard of care. ITLS, for example, put out a paper, I believe this was 2018, that said we think in traumatic cardiac arrest, paramedics should do finger thoracostomy. And what is a finger thoracostomy? I just realized I didn't really mention that before. You make an incision in the chest wall, like you would be putting in a chest tube. You make an incision, you quickly dissect down with either your finger or using a set of Kelly clamps, and then you enter the chest wall itself, which you break the pleura, you put a hole in there, and then you take your finger in and sweep around to make sure that you are not only up against, in the right spot, up against the lung, but you've also broken up any adhesions or anything like that. And then typically after that, you put a dressing, either a 3-sided dressing or a chest seal over top of that wound that you've just created in the side of the chest. That's a finger thoracostomy. It's like putting in a chest tube, except you don't put in a tube. You make a cut, dig down in there, make a cut or make a break into the pleura with your Kelly clamps, and then you put your finger in and you make a big hole there. That's a finger thoracostomy. So simple thoracostomy does nothing except let the air go out if need be, but it does so very effectively. And when you let the air go out, you relieve the tension component, which is the big problem, because almost all these guys are going to get bagged. You can't breathe very effectively if you have an open pneumothorax, but you can be bagged relatively effectively because, again, there's no pressure building. It's all getting let out. So again, I'm not the only one that says this. ITLS, which is a fairly big group and fairly progressive, but not by far like the craziest guys out there, say we should be doing this as well. I will definitely make the case that medics, all medics, if you are a paramedic, I believe it is within your scope of practice and should be within your scope of practice, because it is so important that if you have a traumatic out-of-hospital cardiac arrest, you perform a simple thoracotomy, or a finger thoracostomy, whichever one you want to call it. And I'm now fairly set on this idea, and nothing will satisfy me until I give you some reasons why. Number one, we have to do this at the time of discovery. The patient is not going to survive going to the hospital if they have this tension pneumothorax, because again, nothing we do is going to treat it otherwise. Airway control, intubation, hemorrhage control, all that stuff, nothing is going to treat this other than decompressing that pneumothorax. Number two, finger thoracostomy is the better treatment over needle. Now, needle, again, can be effective, and if it is what you have, then you should absolutely do it. But finger thoracostomy, as we saw, is the better treatment, is the treatment that is more effective and will work better. And you can actually guarantee that it stays patent. Why? Because you can put your finger in there and you know that you have an open path between the air and the chest cavity itself. Now, again, that doesn't guarantee something else can be happening. It doesn't guarantee he's not bleeding into his belly or something like that. But once you put a hole in the side of the chest and you've had your finger in there, you know that that hole is open and it is not a tension pneumothorax. Whereas if you put a needle in, even if you got a rush of air back, is it rebuilding? Is it getting worse? We really don't know. So finger thoracostomy is the better treatment. The relative risk to the patient is exceedingly low. This is a patient that's in cardiac arrest. I'm not talking about a guy that's just got a little bit of chest pain and maybe you hear decreased breath sounds. Patient's in cardiac arrest after his MVC or his fall down the stairs or his stabbed at the chest. It is very hard to find a risky thing to do to that patient because the survival is going to be low to start with. Not 0, 4%, 5%, something like that. It's not impossible to survive it. But the benefit of doing it, in that you have completely taken that part out of the equation and may bring the patient back, is so much it is so much higher than the small little risk that, oh, you put a cut on the side of his chest. You know how you fix that cut? You put a suture in it, or you put a chest seal on it. When you pull a chest tube out in the hospital, there's nothing magical that happens with it. This is a tube that's been sitting in your chest for a long time. What do you do when you pull that thing out? You yank it out and you put a suture across the skin, and then you put a Vaseline dressing on top of that. And that's all there is to it. The relative risk to the patient is pretty low in terms of everything else that's happening. I also believe strongly that paramedic level education already defines the relevant anatomy, defines the relevant pathophysiology, the indications for it, and the expected outcomes, because we're telling people to do needle decompression already. We're giving people the exact same thing. We're saying tension pneumothorax looks like this, smells like this. You treat it like this because otherwise the patient dies. And here's the anatomy that goes along with it. And now, if you're going to do it in the right spot, consider doing the needle decompression over where you would do the simple thoracostomy to start with. We've already defined all that stuff out. The only thing that we actually haven't done is taught the procedure. And that is a relatively straightforward thing as well. Here's how you do it. You identify like 4th or 5th interspace over here, basically kind of go about nipple line, go somewhere between the mid-axillary line and the anterior axillary line. Sorry, I just realized right now you can't see me. somewhere in here in this sort of safety triangle, which is relatively easy to teach and relatively easy to define. You make an incision in the skin, as you see here, and you make it about that big. And again, this is traumatic, and this guy's in cardiac arrest, so we're going to be moving fairly quickly. Again, size doesn't matter all that much. We make a simple incision through the skin. You take a set of Kelly clamps and your finger, and you burrow through the chest wall until you come up against the ribs themselves. You pick a rib, you go over the rib, and then you push the Kelly clamp in through the pleura, and basically break that, break the visceral pleura, you break the, that'd be the parietal pleura. My brain's not working. You break the pleura, basically. You've now created a hole inside the chest. You take your finger, you burrow it through that hole, and you stick it in and you sweep it around to make sure that there's no adhesions and to prove that you are actually in the chest cavity itself. What's the bad stuff that could happen? Well, if you go real low, you could end up down in the spleen or the liver, depending on which side you're on. Yeah, that could happen, but you can do the same thing with a needle. Could anything else happen? Well, you could hit an artery or something. Yes, you could, but you can do that with a needle as well. Plus, the guy's in cardiac arrest. I will take that. If I die, I want you to put your finger in my chest. I don't want to get stabbed with a needle if I can help it. Here is a description from Taming the Shrew of how to do that. How to do that same procedure.
So here we're going to see the first-person video of the finger thoracotomy as performed by Dr. Hinckley. See, the first step here is going to be cleaning the chest wall in the area that you're going to make your incisions. You're going to take your number 10 blade, and then you're going to identify the 4th or the 5th intercostal space. This is approximately in the nipple line, but can be distorted based on the patient's body habitus. You want to stay in the anterior axillary line and make an incision over top of the 4th or 5th rib. You can then use your finger to feel along the superior aspect of the rib. You may have to do some blunt dissections with your Kelly to get through some of the subcutaneous tissue. Then you're going to take your Kelly and you're going to stick it immediately on the superior surface of the rib and apply some generous force into the chest wall. And once you get in and pop through the pleura, you're going to spread your Kellys and you're going to pull out in order to make sure an open tract. You're going to use your finger and you're going to sweep side to side. You're going to clear up any adhesions, and you're going to confirm that you're in the thorax. The last step is going to be to apply the Bolden chest seal. Basically, all you have to do is remove the adhesive dressing and apply it to the chest wall over the area of the incision that you made. Again, this is a one-way valve to prevent air from leaking back into the chest and causing tingent physiology.
Now, I don't want to say, and that's all there is to it. You're all completely trained, because, of course, we're not. I mean, this is a skill. It still takes learning and doing and stuff. But it is relatively that simple, and it can be taught to somebody pretty quickly. Now, again, it's going to be something that you haven't learned before, but we all learn stuff that we didn't know anyway. So it's not like we're really asking somebody to do a whole lot more than learning this one little technique. Really, the argument against it is that, well, it's outside our knowledge base. Yeah, it is right now, because you haven't been taught it, because nobody has said that we need to know it. I'm trying to make the case that, yeah, we need to know it. Let's include it in the knowledge base. The argument against it, you could hurt somebody. Yeah, well, he's already dead. I don't want to say he's already dead, because I hate that argument, but in traumatic cardiac arrest, there's only a few things that you can fix, and you got to fix them right now. And if you don't fix them, the guy's definitely going to die. There's not a lot of gray area with it. So the risk to the patient is so low compared to the potential benefit that I think there's no way you could make the case realistically that it's too risky to put in the hands of paramedics. We have to retrain all the medics. Yes, yes, we do. That's true. When we were talking the other day, there was an argument against it, in that we're worried that medical directors may just be rubber stamping protocols and won't really know what's kind of going on. Well, that's an unfortunate reality, and I can't do a whole lot about that one. If you have a medical director, and I'm not holding myself up as like, oh my gosh, I'm the model. But if that's the case, switch medical director. or get a medical director that's board certified in EMS, that has their finger on the pulse of stuff. Or, if that's the case, I can't fix that. That's just the reality for many of us. That doesn't mean that the patient that lives in your county, but when you have a lousy medical director, should receive any less care or doesn't deserve to live or get the best stuff, when this is clearly within the paramedics scope of, or clearly within the paramedics scope of being able to do, and hopefully soon scope of practice. So yes, doctors are flaky, and sometimes they're in it for the money, and a lot of times they're just really working too much to do anything with you. But I can't fix that. But it is up to you, I would say, as a paramedic, to say, this is something I need to be able to do because I want to be able to treat people effectively. Same thing goes for QA. How do you QA this? Well, number one, traumatic cardiac arrests that you work on scene are relatively infrequent. So it's not like we're going to be talking about doing 1 billion of these a year. You're talking about 2, 3, 4, 5 a year in many services, if that. So this doesn't take a lot to actually kind of QA through. Argument that you are creating a wounds in a body. What are they going to do about the death investigation afterwards? Well, you created a lot of holes in the body to start with, including pushing on the damn guy's chest and giving him a bunch of rib fractures. That's not really a great argument against it. If you saw one of those things that they did there, that was from like Escott, I think, and those guys down around Austin. They actually circle the wound that they make and then write like EMS on the side of it, so they know that this was a incision that was made by EMS. Kind of the final argument against it is that maybe this is a critical care skill and not in the paramedic SOP. Here's my problem with it. While I agree that critical care paramedics are great and we should have lots of critical care paramedics, it's not really something that many people are interested in because there's not a lot of incentive to do it and still work on a ground ambulance, especially 911 response in most places, as much as we would like to have that otherwise. And so if it's in the hands of a relatively limited group of people who are not going out to every run and are not there expediently, it really doesn't do anybody any good. This is not something that can wait for a MICU level crew to come in from 2 counties over from the big hospital way down the road. This is something that you got to do in the next like 3 or 4 minutes. We got to do this now, and it's got to be the guys that are on scene that are doing it. Otherwise, it's not effective. And so why do it? Why even put it out there at all? And the why put it out there? Well, because we can save somebody's life with it. That's why. So it has to be done quickly. We don't have enough critical care paramedics, nor are we ever likely to get the folks with that certification in the climate that we are in. And that climate, by the way, I don't believe is fundamentally going to change soon. But for the moment, for the next 10 years, till we even could get it to happen, I'm definitely going to argue, I want this done to me. I want you to be out there ready to come get me when I'm texting and driving and maybe drunk and crash my car and also probably a little bit high. That's all bad stuff that I've done. I'm being facetious, of course, but that's all on me. But I really want you to be able to decompress my chest at the time and give me a second chance at it. That's what I think we ought to be giving to people. That's what I think people deserve. And you think a little bit too, like maybe it's not in the scope of practice, so we can't do it. Unfortunately, we've got this sort of mindset that whatever you're educated on becomes your scope of practice, and that determines then what you can ultimately do in EMS. When really it's sort of the opposite. What we got to ask is, what do you need to be able to do? What do you need to be able to do then sets your scope of practice, and then we educate everybody up to that point. That's the way that really this is all sort of set up to be. We have to start off with, what do you need to be able to do? And I think in this case, it's you need to be able to decompress somebody's chest. And then we should be setting that as our scope of practice. And then everybody that is getting initial training or continuing education or whatever it is, we have to come up to that standard, to that requirement. So, are we doing this or not? As in, are we advancing things or not? Are we treating people the way that we need to be to effectively treat out-of-hospital cardiac arrest? I say, yes, we need to go for it. This needs to be standard. It is as much an ACLS level skill as anything else that you go and do ACLS level stuff for. If you are able to give epinephrine, you should be able to do a simple finger thoracotomy in traumatic out-of-hospital cardiac arrest. That's my thought. Hopefully I've made a case for you. Hopefully I've educated or given, I'm not going to say educated you, but hopefully I've given you a little bit of education about this thing that's out there and about, the problems that run in with needles. Again, if you have a needle, then do use the needle. But if you are able to do the simple thoracostomy, especially if you're a flight crew or a critical care trained or anything like that, then you should be doing it. But I will make the case again, unequivocally right now. I think that every paramedic out there ought to be able to do a simple thoracostomy for traumatic cardiac arrest. Cool. That was my opinion piece. Hopefully it was a little bit interesting. Hopefully it was a little bit educational. You get a little bit of trauma hours for it, if nothing else. So it is what it is. I would like to come back here in 5 more minutes and talk about one more thing before we end for the day. So we look like we're relatively on time. That's uncommon for me. Again, if you have problems, email us emsgrandrounds@gmail.com. If you want to see our old videos, check us out at emsgrandrounds.org, not .com because that's somebody else, but .org is us. And a couple of questions from the chat. Oh, yeah. Good point brought up by Chuck. I totally agree with. If you're a critical care paramedic, the guys that are trained for this sort of thing, you probably shouldn't really be doing a lot of stuff as a 911 paramedic unless you're in the really, really, really developed system. We really need you on the MICUs. We really need you out there doing that critical care stuff. And if you are just a guy that says, I want to get my education up, I want to be able to do cool stuff, I want to know more, and so I got my critical care, yes, cool, absolutely. But we just don't have that otherwise. So do good work and keep that in mind. Go bug your service director about this now, huh?